and alliances. Therefore, we're here today to recommit to primary health care as the foundation of a strong health system. We at the Ministry of Health and Wellness know that it is time to think beyond the box, reorienting the health system from its traditional approach to managing diabetes and hypertension. The potential access has never been more apparent. With a new set of best practicing health access through cross-sector collaboration is clearer than ever. This contract signing ceremony for the onboarding of additional GPs for the PPP for NCDs program is a positive showing that our technocrats and healthcare workers are anxious to embrace the opportunities of the present and shape the future we all want, an equitable and efficient health system. I'd like to now hand over to Dr. Julia Roporter, medical epidemiologist in the Non-Communicable Diseases and Injury Prevention Unit. Dr. Roporter will provide an update on the PPP for NCDs program, speaking specifically to the patient survey results, as well as give a summary of the pilot report and then do an introduction of our 9 additional GPs, whom we are all anxious to meet. Dr. Roporter.
Dr. Simone Spence, Director of the Health Promotion and Protection Branch in the Ministry of Health and Wellness, and our moderator for this morning's proceedings, Dr. the Honorable Christopher Tufton, our Minister of Health and Wellness, Mr. Howard Lynch, the Director of Policy Planning and Development and the Chair of the Steering Committee for PPP for NCDs, all the directors and officials of the ministry, representatives of our regional health authorities, or participating GPs here and online, members of the media, ladies and gentlemen, good morning. It is my privilege to present on behalf of the steering committee or updates for the PPP for NCDs, specifically the pilot that commenced in July last year. So we'll give an overview of the implementation process. We started in 2020 by advertising 2 expressions of interest to engage our GPs, and those were in April and October. And we also, once we shortlisted those GPs, paired them with referring health centers that were in close proximity. We had 2 cohorts. From the first EOI, we had the first cohort where we had 4 contracted GPs and 6 activated health centers with a target of 200 for that pilot. And in the second cohort, we shortlisted 18 GPs and are now contracting 9 from that batch and have activated 9 additional health centers. We would have done a series of training sessions, including on our clinical management guidelines for diabetes and hypertension, which were approved in 2020. And this was done through a national session for public and private clinicians across Jamaica. And we had various sessions with our health center staff and the general practitioners about the program. We have our steering committee that comprises our chair from the Policy Planning and Development Division in the ministry, as well as other members from that division, as well as representatives from the Office of the Permanent Secretary, the team members, the technical team members from the Non-Communicable Diseases and Injury Prevention NCD unit, as well as the NHF, the Standards and Regulations Division of the ministry. We would have developed several tools for the program, including monitoring tools for our health centers and our general practitioners. We have a PPP stamp that is being used by our health centers and GPs. We also developed material in the form of posters and flyers that were dispatched to the participating health centers to build awareness for those patients accessing services at particular health centers, or NCD registers that document patients with diabetes and hypertension, implemented in 2018, and those were useful to identify patients that were eligible for the program. We would have digitized registers for 8 health centers to facilitate the identification of patients. We would have had our interim guidelines disseminated. They are freely accessible online through the ministry's website and the NCD website. And we also require the use of the NHF card so that patients continue to benefit from those services offered by the NHF, and to also have them linked and flagged as PPP patients on the system. So the pilot started in July last year and was to end in December, but we have extended it to March this year because we have additional activities to ensure that our monitoring captures data that is relevant and necessary to analyze our outcomes and scale up data. So we have here our projected and actual figures or results for the pilot. We would have started with 3 regional health authorities. Unfortunately, Western Region wasn't in the first batch, but they've joined us in the second. And we had 3 parishes, St. Anne, Kingston and St. Andrew, and Clarendon. We had 6 active health centers, and you would recognize that there's a wide range of health centers. We have comprehensive health centers, which is the largest type of health center that serves the largest population, that one in KSA. We would have had district level health centers, which would be St. Anne's Bay and May Pen. And we would have had community health centers, Runaway Bay in St. Anne, Runnington Town and Denham Town in KSA. We use our NCD registers to determine the load of patients that each health center had, and projected a referral quota of about 5%, which amounted to approximately 200 patients, which we distributed equitably amongst the health centers. At the end of December, we have noted that Clarendon did exceptionally well. More than 80% of the referred patients came from that facility. And we commend St. Anne as well as the Runaway Bay Health Center, which overshot their quota. So in all, we had 91 of the 200 patients projected. And we noticed that there were some challenges in KSA for a number of reasons. And we are having dialogue with the parish and the region to work through. So we acknowledge it's a pilot, and it's a new policy, it's a new program, it's a new initiative, and we're learning about how to improve on the implementation. We also know that for St. Anne's Bay, there were challenges in terms of the facility being refurbished. So I'm going to share with you some sneak peeks of results for the patient survey. A rapid assessment was done of the pilot in December to determine key outcomes for the initiative. We interviewed 29 patients, not randomly, they were purposely selected. But May Pen, we had to do systematic sampling, given that they had a large number of patients. And we found that 83% of them indicated they had no transportation issues reaching their doctors. We noted that the waiting time for about half of them was 20 minutes or less. And this is a selling point for the program. Patients in the public facilities are used to spending the whole day sometimes. So we want to promote the program in terms of the less waiting time that the patients would experience. There was satisfaction with the treatment and caregiving, where all of them indicated that they were satisfied in this regard. And there was willingness to continue treatment with the private doctors. More than 93% of them indicated so. For those 2 patients that were not satisfied and wanted to return, we have since advised the regions, because the patients have the right to return to get access to care, to get care that they are comfortable with. And the level of satisfaction with the referral will show that most of them, 82% of them gave the highest rating for their satisfaction with the referral. We also got feedback from our general practitioners, and we polled the 4 of them. And the main issue was that there was dissatisfaction with the number of referrals. So of the 4 GPs, 1 of them would have indicated that they were satisfied, but the others were not getting the numbers that they had expected. And then there were some challenges with the program in terms of the length of the time it took to engage them, to contract them, and for them to start seeing patients. But they were all willing, they all indicated that they were willing to participate and continue with the program. We also got feedback from our regional health authorities, and the main challenge that was expressed was that the referral time took a while to write up the documents, to screen the patients, to put together the referral package. And this is because it's primarily a paper-based system, which can be tedious, especially in the context of other responsibilities, for example, with the pandemic. There were issues with respect to patients being asked to do investigations, the private doctors asking them to do investigation. They were sent to the private facilities to do. Provisions were made for the patients to go to public labs. However, there were some issues. This wasn't as smooth as we had planned. So we need to address that. And patients oftentimes misplace prescriptions, and having to go back to the private doctors was an issue. But there are opportunities to strengthen, and the regions have expressed that they are willing to partner with us because they think that the program is beneficial, and they're committed to working with us. And we want to also engage them in terms of the regions and the health departments identifying those health centers that would benefit most. There was some sort of mismatching that happened in terms of, say, some private doctors being paired with a health center where the patients were comfortable. But there are health centers that would really benefit, and they're partnering with the health departments to identify those health centers and the GPs that would be associated with those facilities. So this is the list of all the facilities in our program. And we have all 4 regional health authorities, and now we have 5 parishes. We're glad to have St. Catherine and Westmoreland on board now. And I want to acknowledge the 4 GPs that started with us in July, Dr. Shane Dockery and Dr. Marjorie Bassel in KSA. We acknowledge Dr. Yolanda Hossang in St. Anne, and Dr. Anil Kumar Kandikatla in Clarendon. We thank you for your support, and we look forward to working with you to scale up the program. We introduce to you our 9 GPs, Dr. Rupert Riley, Drs. Matthew Bird and Diane Williams from Epiam Health Limited, all in KSA. In St. Catherine, we have Dr. Andrew Johnson from Lima Medical, Dr. Tana Ricketts Rooms from Willardine Family Medical in St. Catherine. In Westmoreland, we have 2 GPs, Dr. Kevin Lawrence, Dr. Tracy Ann Spence Golab, and we thank you that you have stuck it out and you're now here to sign with us today. Lastly, I'll say what our next steps are. We have a model where we are introducing the community health aid into the program to assist with the coordination and support for the program at the health centers. We completed a training yesterday of over 30 of them across 5 parishes, which went very well. We are going to continue to sensitize our clinicians, to have dialogue with them about the program, and to ensure that we, continue to support them and give them the information and resources they require. We're going to move into our orientation session with our GPs, as well as complete our pilot activities, which involves comprehensive data analysis of program outcomes, as well as conduct site visits to get more information and observations of processes. We're going to digitize our processes, starting with the adjudication process, and we are going to continue to work closely with our regional health authorities to coordinate and maintain the program and scale it up, which would mean adding more GPs and health centers, setting higher referral targets, and adding other chronic illnesses to the list. Thank you.
Thank you.
Okay, so now that we've gotten a little taste of what the pilot so far has yielded, and I know it's a lot of information, but I really am hoping that the regional health authorities, our GPs that are out there listening, will also want to know, become a bigger part of this program, that they are clearly benefiting from this initiative. And so we really want to get more people on board and make sure that persons are aware of the program so that they will, want to come into the program so that we can create and expand access to health services through this public-private partnership for NCD's initiative. At this point in time, let me now invite Dr. the Honorable Christopher Tufton to now bring his remarks. Dr. Tufton.
Morning to you all. Let me recognize Dr. Simone Spence, Director of Health Promotion and Protection Branch, Ministry of Health. Mr. Lynch, who is not here, maybe online. Dr. Roe Porter, Medical Epidemiologist, Non-Communicable Disease and Injury Prevention Unit, who presented very well a short while ago. Members of the media who are online, and of course, our 4 doctors who are representing this program live and direct here at our offices in New Kingston, maybe online listening on. I really want to just say a big thank you to all those who have been a part of this program, this PP4 NCDs, that's public-private partnership for non-communicable diseases. I think the persons who are here in the room and maybe those online don't need to be told that non-communicable diseases, I like to refer to them for better understanding as lifestyle diseases. Those diseases that you acquire based on your consumption habits, your lack of physical activity, not knowing your health status over time, the consumption of tobacco, alcohol, fats, sugars, salts, that sort of thing. And I'm not going to give the scientific explanation because I'm not a medical doctor, right? So I hope you understand that. But it's lifestyle. That claims most Jamaicans' lives each year. The 18,000 or so deaths, up to 75% of deaths are linked to lifestyle. And so, in a sense, what we are doing in public health, what we must do in public health, is to place significant emphasis as part of our mandate to address health and wellness on what is the main cause of the lack of health and wellness in our population, which is NCDs. And that's what we have been doing over time. But one of the things that we must also accept and admit is that the public system alone is under stress. We're not sufficiently empowered, in a sense, to cater to all the needs, whether on the prevention front or on the curative side. And in a sense, it should be understood that health is not just about public health. My definition of health is that, and health provision and health services, is that whether it is private or public, we have to treat the ecosystem, the infrastructure of healthcare provision as one holistic group. So those who work in for private and those who work for public have to understand that our mission is the same. And we may be organized slightly differently, but we aim to achieve the same objective. If you use that definition to define public health or health generally, it is impatient of debate that collaboration and partnership augurs well and optimizes the efficiency of the response to treating with the population that we both serve. There should be no territoriality between a private doctor and those who can afford to access that doctor, or a health center and those who have to go to the health center. In other words, the nurse in the public health center should be able to talk to the doctor in the private practice to discuss confidentially, of course, a treatment for a patient who may have to cross over between the public and the private. The same applies to the hospital system. And we have to change the narrative and move towards that understanding, that agreement, in order to take advantage of the efficiencies that both segments of the whole offers to the population. And that's what this public-private partnership for NCDs is all about. It is an attempt to pull together both public and private to give the most efficient service to Jamaicans who need it in an area where they need it most, which is the NCD response. Yes. Because any single group cannot optimize that kind of response. So back in November 2020, we started a pilot. We identified a few doctors, I think it was 4 at the time, and we essentially empowered them through contractual obligations to treat with patients suffering from 2 conditions, very popular conditions, hypertension, diabetes, who would have normally gotten their support from the public system to be tended to by those private doctors. And we determined who those persons were based on several criteria, access to the facility and so on. And we worked out an arrangement. And that pilot was intended to assess how that system could develop over time and be improved. You would have heard some of the results as outlined earlier by Dr. Roe Porter on that pilot. Suffice it to say that we are satisfied sufficiently with the efforts and believe that the program should be expanded. And so we have set ourselves a target during the course of this year for some 5,000 Jamaicans to benefit from the services of private practitioners, although they are public patients, in order to achieve the optimization that I spoke of earlier. What is that optimization? That optimization means, and it's reflected in the survey that was done of those patients who were accessing that service. Shorter waiting time, that's what they say, and we agree. But when you go to the clinic, you have to wait a little, you have to wait a while. There are more people, more demands on the system. And what we're doing by outsourcing is to even out that flow, to give shorter access. People are happier when they don't have to wait as long. And as much as our system tries, sometimes it's not that easy to get through right away. More flexible working hours, because again, you can make an agreement, an arrangement with a private practitioner, and depending on their working hours, their practice. Access to more intense consultations at times, depending on what your condition is. You know, they say that the working environment is nicer, it's more comfortable, the private doctor's office. No, this is not to take away from our health centers, because we do try, but let's face it, we have significant stress on our system by virtue of the fact that there's a larger population that's there and that demands that. What we have found in the pilot is that it is possible to work out an arrangement with private practitioners to give the benefit of time, efficiency of service, more patients required. And when those patients need hospitalization, collaboration to understand the history of their condition, the profile of their condition, hospital service. Nonsense policy. If you have a gap in your system, you must be sincere about it and accept that you have a gap. I want to say that this is not to take away from our primary healthcare system. And I want to recognize and celebrate our primary healthcare system, because the reality is our primary healthcare system, our doctors and nurses, our community health aides still remain the bedrock of our health response in our country. 325 health centers across the country. 23,000 people in public health, and they go out every day and they do sterling work in responding to the needs. So I want to big them up, taking away their work because they're not sufficient. We understand the limitations that we were to do it on our own. We're also saying that public and private, as I said earlier, must work together to get the best possible service. So today, after today, we would have had 13 private practitioners on board who can now access services within a private setting. And we would have eased the burden, very importantly, we would have also eased the burden on the public system. Let me repeat that because that's important. The win-win of this arrangement is that we have 13 doctors giving them shorter wait time, more efficient service in terms of environment and so on. We would therefore relieve in the public system the additional burden that they are faced every day by taking those patients and putting them elsewhere, and so give them more time to deal with those patients that they have to deal with. It's a win-win situation, and that's how it ought to be interpreted. So I want to thank those who have come on board, and I want to celebrate the program and those who have been a part of its organization. You would have seen or heard that we have advanced the program too in terms of how we make the arrangements for compensation, where a competitive tender was placed, and one insurance company, Canopy, was awarded the rights to adjudicate. So Canopy has been awarded the rights to adjudicate the claims as it relates to the National Health Fund and the payments to the private practitioner. So we're utilizing the private sector in many ways in order to provide a more efficient service. And this was a competitive tender involving a number of insurance players. So I want to welcome Canopy. We want to say that let this program and its organization and its setup function by virtue of all the stakeholders involved. And we are going to watch and build the program as we go through this year, as we seek to improve ultimately the efficiency of the response. This again is another in a series of changes, in a series of innovations that have been created by the team to improve our public health response. There's a lot more to come. We want to get out of this COVID environment a more resilient healthcare system. I tell people every time I get the opportunity to speak that around COVID, as much as that's important, I am more concerned now with the lessons that we must learn and how we must build to become stronger as a response to COVID. So that neither COVID 20 or this is life. There's always a threat around the corner in public health. And what I want is to be stronger for it. So I am now focused, we are now focused on building resilience. And I believe that this program represents such an initiative. So thank you very much and commendations to those who are on board. Thank you.
Continued leadership in this regard. So at this point in time, we are going to have 4 general practitioners who are here with us today to come up individually to sign these contracts. First, we have Dr. Taylor Ricketts-Rue from Willoughby Family Medical Center here in Kingston and St. Andrew in terms of the, no, sorry, St. Catherine, is it? Yes, St. Catherine.
All right, so you sign and I sign. It's one document. Yes, one document. All right, you go ahead and sign. Never mind. Okay. All right, thank you.
Can present.
Oh,
the package on the conference, yeah.
This package, all right.
Yes, and the contract.
Here we go. Interim guidelines for the clinical management of diabetes.
Oh, I'm sorry.
Elbow.
Elbow? Oh. Thank you very much. No, I think this
Yeah,
is.
but I can't.
Huh?
That's all right.
She can take it?
Yeah.
Oh, okay, all right. All right,
Okay, next we're going to invite.
let me say, Dr.
Yes, sir.
Bird.
Yes, Dr. Matthew Bird from FAO
I've never heard
Medical
somebody with that
Center, which is located in Kingston.
Dr. Matthew. Thank you. Let me- Sir. Appreciate it.
So let's just give a round of applause for the 4 general practitioners who are here and who are representing the 9 that have joined our initiative, so bringing us to a total of 13 private practitioners that are now on board with the PPP for NCDs. At this time, I'm going to open the floor for questions from our media partners online and ask them to use the raised hand feature to indicate whether or not they have questions, and then we'll take questions for our panel. Stephen, anybody online?
Not seeing any questions.
Not seeing any questions in the
Any
chat,
reason?
nor any raised hands. And so because we're closing out our launch of this, signing of the additional GPs to our PPP for NCDs. And it's so good to have such a strong showing from our general practitioners, knowing that PPPs leverage the strengths of the public and private sectors simultaneously. We are completely convinced that significant progress will be realized with the building of strong partnerships, especially with those who are already in the field and dedicated to excellence in patient care. It is impossible to overstate the importance of healthcare. After all, worldwide economic growth and development depend on it. This is why I am so profoundly thankful to all here. This is dedication and remarkable efforts in action. Despite our challenges and setbacks experienced in conducting the pilot, we intend to use the lessons learned to continue to expand the program, and we are confident that our collective determination for joining us today and for the tremendous efforts given to support the pilot at the field level up to this point, and that they will continue to give to this program play out in real time. We look forward to continued cooperation as we forge ahead, charting the path toward improving access to high quality service for persons with non-communicable diseases at the primary care level. The PPP for NCDs initiative has become an important tool in our armament in the fight against hypertension and diabetes, and relieve the immense burden from the public. Presents a third partner as either recipient of services or participant in solutions. So we do hope the media will dedicate some time and space to highlighting the merits of this initiative, as we need members of the public to be enthusiastic participants in this initiative. We are proud of the progress made as we adjust to life with COVID-19 while continuing to rapidly adapt our policies to meet evolving circumstances. Thank you all for participating today and your support as we continue to strive for excellence.
Thank you.
Recording stopped.